Welcome to the Thinking Practitioner Podcast,
a podcast where we dig into the fascinating issues, conditions, and quandaries in the massage and manual therapy world today.
I'm Whitney Lowe.
And I'm Tel Luca.
Welcome to the Thinking Practitioner. Hi, this is Whitney Lowe, and ABMP is proud to sponsor the Thinking Practitioner Podcast. ABMP membership gives massage therapists and body workers exceptional liability insurance, numerous discounts, and great resources to help you thrive, like their ABMP podcast, which is available at abmp.com/podcasts or wherever you happen to listen.
And I'm Tel Luca. Even if you're not a member, you can get free access to Massage and Bodywork magazine, where Whitney and I are frequent contributors, and special offers for Thinking Practitioner listeners at abmp.com/thinking. Hey, Whitney, how you doing there? What's going on?
I'm doing mighty fine, sir. It's good to talk with you again. And we are doing a second episode, I believe, on some shoulder stuff today. Is that correct?
Yes, I'm looking forward to that in celebration of you and me both being part of the Shoulder Jam. We thought we would focus on shoulder, and today we're going to talk about what? What are we going to talk about, Whitney?
Well, we're talking about the mysterious, mythological world of frozen shoulder.
Frozen shoulder.
And yes, what is it? What is it not? How do we figure out what to do about it? How do we deal with it? So big dilemmas there with this particular condition. Lots of debates, concerns, and discussions in the literature about what it is and how to grapple with this challenging condition. So we'll dive into that a little bit today.
Great. Well, I'm not doing so good at following outlines, so I'm jumping around a little bit, but I want to make sure that I mention that there is a handout for today. If you're listening, please go download the handout from Whitney's site or my site. We'll put the link in the show notes. And then we should give a plug to the Shoulder Jam. We'll put links there on our sites as well. It's coming up in May if you're listening to this soon after we broadcast, or it's going to be available by recording too later if you're listening to the recorded version later.
Yeah, and just so that you know what that is, actually it's an online presentation that's going to cover several days with a number of different practitioners, all focusing on shoulder issues. So it's primary focus on that particular body region with lots of good stuff from people around the globe that are going to be participating. So I'm looking forward to seeing what they got out on there.
Likewise. Check us out. So, Whitney, what is frozen shoulder? Don't a lot of things get called frozen shoulder? What are we talking about here?
Yeah, absolutely. This is one of those things where it's really difficult to nail down exactly what we're dealing with because, when you get a common name like this that gets batted around a good bit, a lot of people will have a limitation in their range of motion in their shoulder and say, oh, I've got frozen shoulder, or somebody will tell them you have frozen shoulder because you have this particular type of range of motion limitation. So in our last episode, which was number 37, we dove deep into subacromial pain and talked about how that may significantly limit motion capability in a lot of different planes of the shoulder, and that's the kind of thing that could be easily mistaken for frozen shoulder. So there are some instances where this actually involves some anatomical structures, in particular the glenohumeral joint capsule, and we'll dive into that in a bit more detail. So sometimes this is a problem involving the joint capsule, where it's more technically referred to as adhesive capsulitis, which also has its own problems with the name, and we'll talk about that some more. And then sometimes it's just more of a range of motion limitation in some specific directions, but very, very painful, very problematic for people who are grappling with that.
Okay. So you find it a useful distinction to think about frozen shoulder or adhesive capsulitis as its discrete thing, and you're going to share with us how we might be able to tell, and then you also will give some ideas for working with that. Sounds good. Yeah,
that's where we're going to head. I do want to make one other distinction here that often is talked about in the descriptions of this condition, and then we'll move into talking about some of the characteristics of it in these different phases. But there is often a distinction made between what's called primary frozen shoulder and secondary frozen shoulder.
Yes.
The primary is often what we refer to as idiopathic, meaning we don't have a really good explanation for why it occurs. Seems to just occur out of the blue many times without a particular inciting factor or anything that sort of started it off. The secondary frozen shoulder is one that often occurs as the result of some other type of problem. So, for example, after a shoulder surgery or after another shoulder injury where there is, maybe let's say you've had a acromioclavicular joint injury and you have to keep your shoulder in a sling for a couple months, keeping the shoulder in immobility for long periods of time. That's secondary to the other injury. You will develop frozen shoulder as a result of that. So that is a kind of a clear, important distinction that we often hear about. So,
and it's important for me as a therapist because I may not always agree with the conventional distinctions between primary and secondary in my way of thinking about it, but I think if I think about quote, adhesive capsulitis or frozen shoulder as its own thing, something just arises on its own without another cause, that actually makes me think about it differently. There is some interesting models or narratives or even evidence that says it's almost more like a disease than an injury often.
Yeah, I find that fascinating. I heard another description of it, speaking of it as an underuse syndrome as opposed to an overuse syndrome, which I thought was an interesting way to refer to this because it often develops because of prolonged periods of immobilization or prolonged periods of disuse in that glenohumeral joint.
Right. And then if it's that simple, if we could pin it down to one thing, it would be a lot clearer. Yeah. But sometimes it does seem to be underused. There are times, like you said, that it can be secondary to a period of immobilization or even an injury. And there's a whole bunch of other things that might play into that we're going to discuss.
Yeah. So historically, from the time that this was first described, there have been some descriptions of this condition involving several different phases of it when we talk about frozen shoulder. So what are those phases?
It's helpful to understand that it doesn't, any given client doesn't always follow these phases. And then like you said, Whitney, there's a lot of things that get called frozen shoulder that may not fit this model at all. But classic adhesive capsulitis or frozen shoulder in that subset of people that we can put there often do seem to follow these three classic phases, with the first one being what's called the freezing phase, which is probably inflammatory, although there's sometimes debate about that, but there's some decent evidence that there's inflammatory factors involved in that. And the pain quality there will be distinctive. It'll be achy, it'll be irritable, but really the key indicator there when you're working with it with your client or experiencing yourself is that it will flare up. And that if it gets painful, often the pain will linger, it'll stick around. So that pushing it too hard, doing too much with it, or getting a bodywork, say, that's too aggressive could make the pain worse, and that pain often sticks around. That's a sign that this immobilization could be in the freezing or inflammatory stage. And it's probably, none of these phases are fun, but this is often the least fun of the stages because it's really hard to sleep on a shoulder that's that painful and that motion restricted. And the sleep disruption itself doesn't help you deal with that inflammatory process or whatever it is that's causing that pain or feeding into that pain. And then there's also, a lot of disagreement around how long these different phases last. And everybody says that there's a variety, but then even there's a lot of variety amongst the variety people give. So that in the sources I went back and reviewed before our podcast, it could be as short as 6 weeks for this freezing stage, but other people say it could be as long as 9 months for this freezing stage. Does that fit with how you think about it?
I noticed that as well. It is, yeah. I noticed the same thing as well, that there's a lot of variability in those time frames. And so for that reason, it's something that we have to kind of take with a bit of a grain of salt. And I was also just going to make this one other comment. I assume this doesn't really need to be stated, but I think it's worth at least stating again that note that these three phases have descriptors all having to do with things that are thermal related, freezing, frozen, and thawing. But please do understand there is no thermal component to this condition. That's just a sort of a metaphorical thing that we're talking about there. So,
and then you hinted at this, but even when we call it adhesive capsulitis, maybe that's a metaphor more than an actual histological finding. So that
Yeah.
we have these
Yeah.
metaphorical ways to talk about it: frozen shoulder, adhesive capsulitis, but we need to suspend for a second our decisions about what might actually be going on there as we go through
Yeah.
these descriptors of the phases. So the next
Yeah.
phase after the quote freezing phase, that initial inflammatory phase, would be the quote frozen stage, where it's often still painful, but the
Hmm.
pain might not linger as long. It can still get irritated or flared up, but it'll typically resolve a lot quicker, which is a signal that the inflammatory processes are starting to resolve some. But
Yeah.
often it'll still be pretty stiff. Sleep can still be difficult, but often it'll be getting better. You won't always be woken up every 2 hours like you can be in the freezing phase.
Hmm.
Yeah. And then the timeline that's often given for that is anywhere from 4 to 6 months beyond that initial inflammatory stage. That,
And we will be making some distinctions a little bit later on in our discussion here between sort of structural and functional differences in terms of what might be causing this. And some of those can have an impact on how long those stages go and the way in which a person experiences those stages as well. So those are just other variables that get added into the equation that make those things hard to pin down, I think.
okay. Well, I look forward to hearing your thoughts on that.
Yeah.
So, ready for the third stage?
Yes, let's have the third stage.
Third stage is the thawing stage. Third and hopefully final stage is the thawing stage, where it will be more stiff than painful. There's still movement restriction, say, but it's often getting less and less painful. Although there can still be, a certain level of discomfort for sure. But the big thing is that there is a sense of improvement. Although I got to say too, there's an exception there too. This can be a plateau that can go on for the classic times given are anywhere from 6 months to 2 years. But there is reasonable evidence that a lot of people spend an indefinite amount of time here, either in that phase 2 phase, the frozen painful stage, or in this thawing stage where it's more stiff than painful. But
Yeah.
but
You know,
for a good number of people, this is a sign that it's drawing to a resolution, at least to a major degree, and that's that improving. The sleep gets better and things like that. And so those are the three phases: the freezing, frozen, and thawing. And then in the best of all worlds, you live happily ever after. You're thawed and you're good.
That's right. Yeah. You know, one of the things also that I found interesting, I ran across some discussions about this, that these phases, and especially the length of that thawing phase at the end of it being somewhere around 2 years, there's been a lot of discussion in the literature saying that frozen shoulder is something that just runs the natural course with most people and will generally resolve within about 2 years.
Yes.
And one of the other authors that I was reading saying they looked into this and doing sort of an overall review of a lot of different studies found that actually isn't true or isn't consistent
Yes.
in a lot of the different cases. And so like you were just saying a moment ago, this can often go on for a very long period of time, and it's not necessarily going to just naturally dissipate on its own. It may do that in a certain number of people, but that's not something I think we can count on happening with them.
I think you're talking about Wong, 2017, who said that, yeah, there's this thing we've been telling our patients for years. He's a physiotherapist, that there's a natural history, that it runs its course, that you got to be patient. And for a good number of people, that's true. But his meta-study, his meta-analysis of different reviews said that actually there's a whole lot of variability, and there is a pretty sizable group of people that it doesn't seem to even follow that 2-year time cycle, that it keeps on being painful for people. But I'll put a reference to that in the show notes.
Yeah, good. So those are some of the characteristics on those different signs or those different phases of it as well. So we also drilled down and got some more specific stats on who is particularly vulnerable to this, because there are some categories of people. And again, I would just want to emphasize this is really helpful information to be pulling out. And another really good reason why a detailed client history is so important and so valuable, because there are some interesting things that we're going to get into here in just a second, talking about some of the characteristics of who gets this problem. And some of these things won't come up if you don't dig deeply with your inquiry in the history. So that's a good reason to look into some of these things and make sure you're asking those questions to probe deep enough for some of the background factors that might be present with people. So
I'm with you. In spite of the fact that we just said that the timelines are really variable, that is such an important question. How long has this been going on? So at least you can begin to make your working hypothesis about where they might be in the cycle.
Yeah, absolutely. So what are some of those statistical factors of who happens to get this?
The incidence rate that's often given is somewhere between 1% and 2% of people overall. Although there are so many things that are called frozen shoulder, it's a little hard to say. But 1% and 2%, it sounds pretty small, but it's actually, that's a good number of people, you know? That's 1 in 50, 1 in 100, which means you're going to, probably encounter that, several of those people a year in a medium-sized practice. It tends to be 4 times more common in females between the age of 50 and 65 than in other populations. Some of those people that have the adhesive capsulitis / frozen shoulder have a history of surgery for the shoulder. And there's a theory that perhaps it was a co-infection that happened during the surgery that started the inflammatory reaction, or an inflammatory reaction to the physical trauma itself. I think there's probably more support for the infection thought now than there is for the mechanical thing. Oh, that varies quite a bit. There's still quite a bit of people that are thinking the mechanical factors are important. But in my own, maybe I'm just talking about my own thinking.
Yeah. I want to also backtrack for just a moment to the one you said before with it being 4 times more common in females, because I've always asked this question, and I've been asked this question numerous times by students, like, what is the reason for this? And I, at least in my perusing through the literature, have never been able to find any good explanation for why that is so much more common in females. I don't think we have a really good understanding of it. We just know that happens to be the case.
Yep, I don't know either.
Yeah. Anything that you've encountered? Yeah. Okay.
No, I don't. But I've seen that. If I think back on the people that I think probably had this category of condition going on, they are maybe all female, the ones I can think of. So not to say that men don't get it. Even if it's 4 times more likely, that means that there's a lot of guys that deal with this. But the classic demographic is female, and they get in that middle age, 50 to 65.
Right. Yeah.
So you mentioned periods of immobilization being a contributor. Paul Ingram, who does the painscience.com website, he has a very thorough collection of the research on it, and he does a really good job, as usual, of kind of laying out some of the theories and ideas about it. I just got to give him a kudos there, and along with the caveat that he's really good at, I think, distinguishing when he's talking about his opinion and when he's talking about the evidence, but they're both woven in there, and I don't always agree with his opinions, but I love his thoroughness in his research. He has a theory that injections, even a vaccination injection, if it does somehow compromise the joint capsule, could introduce skin bacteria and initiate that inflammatory reaction. He says this is conjecture. I have no evidence, but that's an interesting thought.
Yeah. I was going to mention this was interesting. I was reading the similar thing of the stuff on Paul's site and about the injections. And I just got through with my second COVID vaccine 2 weeks ago.
Yes.
And I have developed what feels to me like a capsular restriction, weirdly enough, in my elbow. And when he said that about the injections, I thought, wow, that's really interesting, because what I feel is like I can't straighten my elbow out completely. I get a pull on the anterior side of my forearm, and then when I try to flex it fully, I get a pull on the back side, on the posterior side of my elbow. So it feels like the capsule is restricted in both directions, and it feels deep. It doesn't feel muscular. It really feels like the deep connective tissue in there. And I just thought, wow, I wonder if that's related to the injection, because there are so many kind of weird side effects that people are reporting from the COVID injections too.
Well, okay, since you're your own guinea pig, do you think that's mechanical or inflammatory?
My guess would be it's inflammatory.
It's a trick question,
something having to do with inflammatory.
Inflammatory, yeah. No, I'm with you. I'm with you being inflammatory,
right,
but with mechanical correlates is how I think about it. That it probably wasn't the mechanical puncture or the injury to the fascia, say, that caused the stiffening. It was probably, who knows what, the mRNA itself, or who knows, somehow a reaction. that
Yeah.
is
Well, the thing that was weird is, I got the shot in my shoulder, and it's my elbow that
yeah,
has the problem. So,
yeah.
that's why it seems to be
So if
some
we're
kind of
going
reactive
to
inflammatory.
speculate, we could say maybe it doesn't even require a puncture of a capsule. Maybe just an inflammatory reaction somewhere nearby could initiate some of that
Yeah.
stiffening response. I think that's pretty common,
Yeah.
even on short term. But when we
Yeah.
get, I'll check with you next episode and see how that's doing. But if it were to go on longer, then we would start to call it a condition and such. But I think there's lots of those kind of
Yeah.
things that happen in reaction to different
Yeah.
things.
Yep. So,
Well,
what else we got there?
well, more. This is interesting. The non-dominant arm is more commonly affected. So if you're right-handed, it's more often your left shoulder, and it's usually one-sided condition, but it can definitely affect both sides at once on some people. And then it's interesting too that if you've had it in one shoulder, you are more risk of developing it in the second shoulder as well, which also starts to suggest maybe it's not a mechanical primary cause that's causing the frozen shoulder in those people at least. It is a lot more common in conjunction with other systemic diseases. Like 12% of people with diabetes get a frozen shoulder at some point, and 30% of people with frozen shoulder / adhesive capsulitis are diabetic. So 30% of the people that have that condition are diabetic. There's also things like thyroid issues, cardiac disease, Parkinson's, and then a lot of speculation about other chronic low-grade systemic inflammation conditions like metabolic syndromes and other kinds of things like that contributing to people's shoulder symptoms.
Yeah. This is one that I find really fascinating. I mean, there's certainly, like, when you look at all those statistics and a number of those things that all having something to do with sort of metabolic components, it really, this is one that just really makes me ponder what the connection relationship is there and why the glenohumeral joint. Why does it go there and not seem to affect other joints to the same degree? It's puzzling.
Well, yeah, the why does it go there is a really good question. And then even maybe more puzzling is why now? I mean, after something like an injury that's obvious, or after a period of immobilization is obvious, but then there's other times it just seems to happen. We don't know why. And that actually, in my way of thinking, I'm starting to come up with, not that there's clear categories, but the when question, I think, is probably a psychosocial question. The where question might be the biological question. Sorry to draw distinctions that probably don't belong there. But why now? I'm thinking of, like, there's so many factors, including a psychological profile that's been done for people with adhesive capsulitis. This is one study, so I don't think this is widely accepted, but this is a study that's just published last year. Chiaramonti out of Italy had 76 adhesive capsulitis patients, and they gave them various psychological profile instruments that are pretty well validated. And it seemed like at least a decently designed study at my first glance at it. But they showed the pretty clear psychological profile of people with primary adhesive capsulitis. That is, people that just arose on its own without an injury or something like that. And they said that there's a prevalence of perfectionism, low levels of novelty seeking, and high levels of harm avoidance in that population, quite significant statistically in that group of people with primary adhesive capsulitis. So I find that really interesting. Yeah, it is interesting. I want to for sure stick in the caution that we don't know what that means. They did in their study design correct for pain in general. They attempted to correct for that. So it's not like, of course, people in pain are going to have, they're going to avoid novelty. They're going to avoid harm just because they have pain. But their control group had pain too as well. So it's just, this points to the fact that there are some other probably non-mechanical factors involved, as there are in a lot of inflammatory reactions. It's a kind of reactivity that for sure is metabolic. It is physical, and it probably is psychological, our psychological immune system, and maybe even beyond into collective responses too, that might have parallels all the way through.
Yeah. It was fascinating. Like what doesn't it reach into? It seems to reach into all of these different things. Metabolic things, connective tissue problems. You had mentioned also too the very high correlation with Dupuytren's contracture, also, which was kind of interesting.
50%, they say, of people with adhesive capsulitis also have Dupuytren's or Dupuytren's, which is the stiffening of the palm fascia as well, or cords in the palm of your hand. Yeah, and that suggests that you can make what you will out of that, but it suggests that there is some sort of systemic connective tissue reactivity or perhaps disorder that the shoulder joint is a part of.
Yeah. Yeah.
Any other points you
So,
want to make about who gets it, Whit?
yeah, I think that covers the majority of things that we want to look at. I also did run across one mention too that had said that there was some correlation with obesity, which to me kind of goes into a lot of these other metabolic factors, I think. So we're looking at overall things that may be related to some types of systemic metabolic things and lifestyle things that are all factored into
Smoking is
likelihood
another
of
one.
developing
That's
this.
right. That's
Yeah.
right.
Yeah. Yeah. So,
Okay, so why does it
yeah.
get stiff? Do we know why adhesive capsulitis or frozen shoulder even gets stiff? Do we know the mechanism?
Yeah, so this is another one of the things that's really kind of puzzling and difficult to sort of nail down. But what we do see now is sort of a distinction being made between what we refer to as structural causes versus functional causes. So looking at the sort of structural condition first, this is the one that would more characteristically be defined as adhesive capsulitis, where there is a pathology of some kind with the joint capsule, the glenohumeral joint capsule itself. Now, formerly, there was a lot of narrative around this that described the very fact that when the shoulder is in a neutral position, just because you have such a great range of motion in the shoulder, there's a lot of sort of slackness to the underside of the glenohumeral joint capsule when you're in a neutral position, so that when you raise your shoulder out in full flexion or in full abduction, that slackened tissue on the underside becomes taut. But there's got to be enough room for it to move and sort of stretch out and lengthen. So it's got to be kind of, you can envision this as just sort of like a fold in it to allow it to come back to a neutral position, since it is a non-contractile tissue.
Yep.
But the original descriptions often described that we were having an adhesion that was sticking together the fold in that inferior glenohumeral joint capsule. And that's what was causing the restriction in adhesive capsulitis. And some of the more current descriptions that I was running across now are saying, well, we're not seeing so much that adhesion of the fold as we're seeing something that seems more like a sort of a shrinkage or kind of essentially a contracture of the glenohumeral joint capsule, of sort of fibrously contracting to prevent full range of motion in there. So that seems to be what some of the tissue pathology may be associated with in adhesive capsulitis.
And I remember some pretty detailed debates about exactly which part of the joint capsule or which ligaments were involved. But again, the more recent sources I went back and reviewed, getting ready for our conversation, they're avoiding that. They're saying, well, there's so much variety and there's so much debate that maybe it is a non-specific contracture of the entire capsule, say, more than a particular ligament. Like classically, you used to say it's the anterior part of the capsule, say, that would inhibit external rotation. Well, that's true in some people, apparently, but maybe not in everybody.
Yeah. So those are some things that we can kind of think about as guidelines. But again, it may, like you said, it may be really somewhat unique among everybody, and some of those things those patterns may not follow through as easily. But so we have this structural one that's the connective tissue problem. And then there's a very large percentage of these people which seem to have what's referred to now as sort of a functional frozen shoulder, which seems to be a lot more of a neurological problem, where there is excessive muscle guarding and muscle restriction, so that your joint range of motion is limited significantly, but predominantly by neuromuscular involvement. So, for example, we are having muscle tendon units that are being sort of hyperactive and preventing certain types of movement in these specific planes. And to emphasize, we'll talk about this a little bit more in just a moment, but we do tend to see some characteristic patterns with these external rotation of the shoulder being usually the motion that's limited the greatest. And then abduction also limited very significantly. And in some of these people, not quite as many, a bit more limitation in internal or medial rotation. But those things those patterns of restriction oftentimes can be indicative predominantly of muscle involvement, which we found very interestingly, and you referred to this too, of the fact that we have a lot of these people who were anesthetized and who had diagnoses of frozen shoulder, and then under anesthesia you were able to move their shoulder around very easily. So there wasn't some binding contracture in that connective tissue, but something with the muscles that were anesthetized was doing that.
That's right. That's really it was Hallman 2015 who did a study. He only did 5 people, unfortunately. She actually only did 5 people, but when she put them under anesthesia, all 5 of those got quite a bit more movement, and they'd all were scheduled for adhesive capsulitis surgery under the assumption that it was a structural or connective tissue contracture. And she has a cool video that I'll put in the references, and then that replicates or is along the lines with a more informal study Robert Schleip, my friend and mentor, did a long time ago, where he tagged along with a knee surgeon, and he did measures of people's shoulder motion awake and then under anesthesia, and he found that 2 out of the 3 people he checked got considerably more motion under anesthesia. 1 of them didn't. So there is a certain, we can say that maybe at least some for sure, of these shoulder restrictions have a non-muscular contraction component. Have a muscular contraction component. Because when you go to sleep, your muscles relax. So if your muscles are relaxed and it gets better, it wasn't the connective tissue that was holding it passively stiff.
Yeah. Which makes us wonder, maybe there's a role for anesthesia in the assessment or evaluation process too. Can we just put people to sleep and see if their shoulders will move there as a distinguishing characteristic? But
we can try that. Put them there's all kinds of things. And then the other interesting factor is that, again, this is an opinion just put out there. I haven't found a really hard reference about it, but they say about half of adhesive capsulitis surgeries show actual tissue pathology. There's visual pathology only in about half of those. So a lot of people, they've narrowed them down. They think you're a candidate for surgery based on everything we know, and then they do the surgery, and there's nothing visually pathological inside the shoulder.
Yeah. And I think that's one of the reasons why it is helpful and valuable if we can find some ways to try to make some distinctions between these structural versus functional facets of it, because you don't want to send somebody in for surgical interventions for a capsular adhesion when it's primarily a neuromuscular thing that's going on there that's going to be possibly could be addressed through some other conservative measures that wouldn't be as invasive as a surgical procedure. So
so we don't want to send someone for surgery if it's not structural. Are there other reasons or other ways that information is useful to us? Why else would that be important, that distinction?
I think it's helpful in that if we have some idea if this is mostly a connective tissue involvement versus a neuromuscular involvement or vice versa, then our treatment strategies might focus more on the things that we have a sense might be more neurologically oriented. We might focus on a lot more movement-oriented things that we feel like can really enhance or encourage neuromuscular relaxation through those areas, as opposed to trying to do some things that we have a sense might be forcibly able to elongate or make the connective tissue a little bit more pliable. Although, again, there's some really interesting research that's saying there's not very much supportive evidence for the capability of stretching contractures themselves.
Yes, right.
So those are some challenges and dilemmas, but I do still think it's valuable and helpful if we're able to identify those things to some degree.
I'm on the fence about that. Or let's say I'm not even on the fence, I'm on both sides of that fence. Because I find it's really interesting, and my training and my practice for these decades has been, if it's structural, that's going to make me think one way about it, and if it's functional, I'm going to think another way about it, even work in different ways. So in that sense, I think there probably is an important role for that distinction. It informs the way I work with someone. Now, on the other side of the fence, I think, does it really matter to me as a hands-on practitioner? Because I'm still going to try something. I'm still going to get a working hypothesis, try it, and if it seems satisfying and seems to be getting good results, I'm going to continue it. And if it's not, I'm going to change it. And I don't think it's useful for me to start with the assumption it's not going to change, which is sometimes goes along with the structural assumption. If it's a structural problem, the plausible and normal, conventional thinking would be, we're not going to change that. There's not really good evidence that manual therapy changes connective tissue in a permanent way, except in certain cases, which probably don't apply here. And we can think, well, we can have a lot of effect on neurological inhibition. We can relax muscles, we can increase stretch tolerance, we can increase the safety. So maybe the functional ones are more our bailiwick, you could think. But I don't go there. I don't think, I think we can help both of them. And even some of the tests, like if you get warmed up, it's said, if you get warmed up with exercise and your shoulder is more mobile, that points to a functional restriction. Some people say, I don't know about that, because connective tissues do get more pliable when they're warmed up, too, even structurally. So I think it's really hard to tease these apart. It's really hard to tease them apart. And maybe as a practitioner, it's great to make a distinction so I know how to think about it. But again, I'm going to work it and see if it helps. And if that helps, I'm going to continue that. And if it doesn't help, I'm going to do something different.
So let me sort of press into that just a little bit more here. So
Yes.
how would you warm up connective tissues of the glenohumeral joint in terms of creating a thermal change that might make that tissue more pliable?
Okay, yeah, I'm not someone who uses thermal approaches in my treatment. So I wasn't saying, I would do that as a diagnostic. I would find out if somebody, when they're exercising, when they've warmed up their whole body, let's say, has more range of motion. But honestly, like I said, I'm not spending a lot of time trying to tease those apart. I'll put them on the table and see if a very gentle, supportive approach gets results, then I think, okay, I probably haven't used a mechanical force yet that's caused any sort of tissue change if that's even possible. What I've done is I've probably de-threatened movement in a way that they can move more. Great. That's really useful. And
no,
you go ahead.
I was thinking also in terms of just in terms of the treatment approaches. For example, if we had sort of clarified that something might be a bit more neurological than structural, then maybe some of our treatment strategies that might be trying to, I hesitate to say the phrase, but maybe fool the nervous system a little bit into increasing range of motion, like, gentle eccentric loading where the person is thinking about pushing in the opposite direction, but they're actually lengthening and going in the direction of the barrier. Might those things be more helpful in a situation like that?
Well, if they were more helpful, then I would go the other way. I would try them and see if they were more helpful. If they're more helpful, I think, okay, that was good. There probably was a neurological component. That like the treatment becomes the test. That supports my hypothesis. I like the fool the nervous system thing though, because what we've done, let's say in an inhibited motion that you have someone press into, is like, oh, we fooled you into thinking you're safe. Guess what? You are.
Right, that's right. Yeah,
We actually we de-threaten that direction by having someone play with it, either with contraction or even supporting into it, passive or active, and we're reminding the nervous system that maybe you don't hurt as much as you thought, and especially toward the later stages, that recovery stage or after it's become habituated, that is so useful. Just that reset of the protective habits.
Yeah, I want to also just ask you a question too about treatment approaches in here that's related to both these things, and I know we're going to talk a little bit more about some treatment things later on. But as we're talking about this right here, it came to mind. One of the things that I have seen so frequently with a lot of clients who have this condition is this sort of defeatist, catastrophizing kind of mindset about like, I'm never going to get better. Like this is going to be going on for a long period of time. It's very easy for people to kind of get sucked into this, like lack of progress kind of thing. So is this one of those things? I certainly think that there's value in anything that we can do that can show even the smallest incremental improvements being really valuable for therapeutic progress by showing people, hey, you couldn't do this last week, and now you can. I mean, this is even one of those instances where I think like even something like measuring range of motion with a goniometer might have some really value here. And like, it's like, look, we have a numerical proof of greater motion this week than we had last week. So,
that's so important, like your numerical movement range or less pain. The fact that I can change your pain is a hopeful sign. It's not, your pain isn't permanent. And then, yeah, you're right.
Right.
There is that psychological profiling study showed a
Yeah.
prevalence of perfectionism. My shoulder has to be perfect for it to be okay. Low levels of
Hmm.
novelty seeking. I better not try that. High levels of harm
Yeah.
avoidance. Don't do that. That might be built into uh, the complex of causative or correlating factors that are part of this condition. So yeah, I
Yeah.
think anything I can do to begin to soften the edges of those reactions, whether they're inflammatory reactions or guarding reactions or assumptions, narratives, anything I can do to soften those can help. And usually it is
Yeah.
supportive more
Yeah.
than challenging.
Hmm. Yeah. So those are important things, I think, with any of our treatment approaches to really to keep in mind as we're trying to find the best, most effective results in working with this, because it can be certainly so challenging to find those effective strategies, regardless of structural versus functional, or whichever it is.
Is it a good time to say a little more about how you sort those out? Some of the methods or tests you would do to start to make that
Yeah. So let's
guess on your side?
look at this kind of assessment wise, and we can also look at this in terms of some other things that will be helpful to maybe distinguish it from like some of the things that we were talking about in our last episode, like the subacromial pain syndrome or rotator cuff disorders and things like that.
Mm-hmm.
I do find it valuable to try to dive a little more deeply into the assessment process and seek patterns that might be indicative of one of these things going on versus the other. So first of all, as we mentioned, if there's a way to try to, if you can look at this at all with decreasing the role of the nervous system and try to find if there is capsular involvement of restriction versus a neurological one, that is really helpful. But it can be really difficult to tease those apart sometimes if you don't have the capability to do something that will turn the nervous system off, like anesthesia or something like that. I mean, there's always, have your client drink excessive amounts of alcohol before they come into your treatment and do the evaluation and see if that's impairing the motor function.
Oh, you're talking about home
But that's not
experimentation with
advised.
anesthesia, right?
That's right. Something like that's right. Probably not advised. But one of the other things that I would encourage in terms of some distinctions, certainly between this and some of the other like subacromial pain syndromes, is look for those patterns that would indicate, usually with the subacromial pain syndrome and rotator cuff involvement, you've got the primary nociceptive driver in that instance is contractile tissues, being the muscle tendon unit. So if you, for example, try to perform a resisted abduction movement with no motion occurring at the joint, and that is painful, especially up in the region of the anterior and or lateral shoulder region, that would tend to be more indicative of something like a subacromial pain complaint than would be a frozen shoulder, which is generally going to be painful during active or passive movement, but not painful during the resisted movements of abduction or flexion of the shoulder, because you're not moving the capsule, not moving the restricted tissue. So when you do those resistive tests in a static isometric position, that would be a way to help distinguish between the more muscle tendon unit oriented subacromial pain and that of something in frozen shoulder.
Okay, so if you do a resisted isometric contraction and it hurts, go listen to the last episode. And if that isometric contraction doesn't reproduce the pain, you're in the right episode here. Is that right?
Keep listening. Yes, right.
That's right.
Yeah, there we go. Something like that. Yeah. So another thing, you mentioned this earlier in our discussion too, that there's different portions of the capsule that may be involved. Some of those patterns have been described in the literature with particular types of restriction, but as you noted, they're not always entirely consistent, but I do think it's still at least helpful to understand a little bit about why you might see some of those patterns. For example, when the anterior or superior part of the capsule is involved, the descriptions usually are you see the greatest range of motion in external rotation of the shoulder with it in a neutral position. If it's the underside of the capsule where that axillary pouch is that we formerly thought was getting stuck to itself, the underside of the capsule at that point usually is more problematic when you try to externally rotate the shoulder from an abducted position. So this would be the position that you would use if you were trying to reach up behind yourself and scratch the back of your head, for example. So with the shoulder being in abduction and external rotation simultaneously. And then the the sort of third pattern was if there seemed to be more capsular restriction on the posterior aspect of the capsule, that was more likely to show involvement with limitations in medial or internal rotation of the shoulder.
Mm-hmm.
So helpful, I think, to look at some of those things, but not to put all your eggs in that basket of really trying to narrow down and say, oh, we can know for certain this is where the capsular restriction is if that pattern happens to be there, because there are some other things that can be factors there.
Well, I know I made a case for why I don't tend to start with a lot of tests myself, but use the treatment as the testing. But what you just described there is using specific motions or checking specific motions and combinations of motions to identify what might be involved. I think that's really useful.
Yeah.
And I think I would use that, again, to form my working hypothesis as to where to start. Because I'm not just saying nothing matters, let's just try the shotgun and see what works. That's part of the skill that comes with doing this again and again, and maybe with studying something as specific as you're offering us. When you can really dial it down, that makes you really intelligent and really efficient about where you can begin at least your hypothesis in your work.
I think that's true. And the other thing, for me, one of the reasons I like doing this in advance with a bit more detail is that it gives me some understanding of what motions I need to really watch for when I try to move my client around on the treatment table or try to get ready to do some positioning things. To be very cautious and know, oh, this is a motion that I know they've had some problems with, so I'm going to be really careful here. And I'm also going to let them know I'm being really careful here, and I'm really going to watch this and make sure we don't go into the place that's uncomfortable for you. So
that's
those
important.
Are things that I think are really helpful. Yeah.
And how do you reconcile that with the statement you've made before about special tests not necessarily being so special? That's like, I listened to Jeremy Lewis talking about this recently. He says it's really hard to be accurate in terms of reliability for these tests, in terms of identifying the specific structure. And I know you know that and you agree with that. But he says that the test can be really helpful to identify a painful movement or a range. I mean, we're checking for pain, he says, more than saying being definitive about identifying the structure involved. How do you reconcile that for yourself?
Well, for me, the thing is, again, I think people tend to use a lot of these special tests in a bit more isolation. And it's interesting when I hear a lot of people in the world of orthopedics, and this is across the board, orthopedists, PTs, athletic trainers, massage therapists, chiropractors, whoever, when they talk about the use of these special tests, they talk about them frequently as isolated evaluation tools and evaluation methods without talking about first going through and identifying particular patterns of restriction that would point to one particular or one or two particular tissues being your major suspects. It's almost like they jump through that part and then go immediately to just performing some of these special tests because it's quicker to do that. But I think you miss important information that you're building a case. It's whole like a detective process. You're trying to gather clues and build a case and is there enough evidence to point us in this direction? And one or two special tests alone don't provide the sufficient evidence in the absence of looking at some of those patterns like I was talking about before of what happens during active abduction versus passive abduction versus active and passive versus resisted external rotation, those types of things. So for me, it's all about the patterns and are you building up enough evidence to indicate one particular type of thing being more suspect than another.
Okay, so I like the suspect piece because what you're saying is that you're using the test to form a hypothesis, not a diagnosis, say. You're going to identify in your mind a structure, but knowing that structure may or may not be the structural part as much as the nociceptive or the sensation or the perceptive part of what's involved.
Yeah, absolutely.
Are there any other tests you'd want to mention or assessment factors?
Well, one of the most common things that's used a lot for evaluating this is something called the Apley scratch test, where basically you're just trying to put your hands in a position to either scratch your upper back or lower back region. And that tends to, test, for example, when your hand is trying to scratch your upper back, you're looking at abduction and external rotation range of motion in one shoulder, and the lower shoulder when you're trying to scratch your lower back is adduction, adduction, and internal rotation on that shoulder. And then you switch them, go to the other side and compare them and just see, is there a significant difference in range of motion, or is somebody unable to do those things because it's just too darn painful to do it? So it's a kind of quick and easy range of motion evaluation that can give you some important, information about what's going on there. But the thing that I also find interesting is that, in teaching this in a classroom, I would often go through these procedures with people, and we've got lots of people in there with non-symptomatic shoulders, and they do these Apley scratch tests and find very significant differences between sides, like you mentioned earlier, the dominant versus non-dominant side
In terms of motion?
range of motion. Yeah.
Yeah.
And so does that necessarily mean there's a pathology there? Not necessarily, but we already have in a healthy individual significant differences between range of motion on those sides. So you got to be careful about how much weight you put on those procedures as telling you something, when in essence they may just be reflecting a pretty close to normal situation that we see a lot of times anyway.
Nice. And then for myself, more and more, I think I'm thinking about pain as its own thing, so that I'll do those tests, those similar tests, but I'm looking not for necessarily where the motion restriction is, but where the pain provocation is. And then I will think about going to work with that sensitivity or that guarding or whatever it is. I'm coupling that from the motion restriction, because it may or may not be related. Sometimes you get things less sensitive by getting them more mobile, but not always. And sometimes things are sensitive without being immobile. Yeah,
right. So how, with those things in mind, how would we work with this? What are our strategies? We mentioned a few things already. What kind of things also do you like to focus on here?
Well, I'll put some stuff in the handout as usual, and I know you put some really rich text about tests and things in our last handout. Anything you want to say here about this handout? Is some of last handout stuff apply to this topic as well?
Yeah, absolutely. And I think we'll try to do a similar thing here of put some clarifying characteristics that would be helpful in identifying this particular problem and discriminating between this and some of the other common shoulder complaints that we might run into as well. So those would be some things that we'll try to make sure we include in there.
Great, because I want to say that a lot of the techniques I showed in the last episode's handouts are also ones I would use for this situation. And then I'll put in some specified ones I might use for something I suspect is in the realm of a inflammatory reaction or a frozen shoulder kind of thing. And then I'm also going to put in a chapter on the shoulder, on the glenohumeral joint rather, from the Advanced Myofascial Techniques, Volume 1. I'm going to put that in the handout too, which again covers one of the movement directions that I think is the most helpful, and that's the inferior glide or inferior translation of the humerus on the glenohumeral fossa. That's one that I want to make sure is desensitized and mobile if I can. That seems to help so many people. In fact, I was so sure of myself, Whitney, probably the first 10 years of my practice, that I was one of those guys that I can fix 99% of frozen shoulders. I really thought that. And maybe my track record was really that good until I practiced. Probably what happened is I practiced long enough and saw enough clients to start to run into the ones that I could make better, but then the improvement didn't necessarily last. And then I really had to go hit the books and do the homework and realize, okay, there's a lot more to it than just say the bag of tricks that I developed and learned in my first 10 years. And so much of it becomes, I'll go through it now in terms of phase. Like if I suspect someone's in that inflammatory phase, that first phase, the quote freezing phase, then I'm going to do it. That's again where it will flare up easily or where the pain could linger once it's provoked. Then I want to do very careful experiments around how much movement is okay. Once I've made that connection with the client and help them settle, that might be a lot by itself. But even once we got that, then I'll do very careful experiments to see exactly where is the painful range or where is the painful movement. And then how much support does it need? How much challenge does it need? And I will give the homework of tell me how this was later. Keep track of it. Make some notes so you can come back next time and tell me, did it get better and stay better? Was it better and then flare up later? Because we're going to learn from that. And that's really what I need to know is like, how do I need to dose and pace the work I'm doing? But my goal is really there in that first phase, that inflammatory phase, or pain relief. Education, meaning I'm helping them start to think about this as a process more than a fix, something that they need to. This is a process of caring for your shoulder, not fixing your shoulder, especially if they've been at it for a while already. So if they've tried a whole bunch of stuff and they often come to see me as a later stage practitioner, which is often the case, then it's like, okay, so maybe then it's a process of getting to know what your shoulder is comfortable with and can do, and finding ways to give it that more than getting your shoulder to cooperate with what you'd like it to do. So that sort of reframing and re-education, that's the first phase, the groundwork. The next phase, the middle phase, or the quote frozen phase, where it's more, seems to be more about immobility than pain per se, although pain can still be there. I'm still doing pain relief, but I'm doing more reassurance. I'm continuing the gentle mobilization. I've learned how much we can challenge, how much we should support, and I'm mostly fostering patience in that time, because a good number of people do get better, even though, like we said, not everyone does, but a good number of people do get better after a certain period of time, no matter what they do or don't do. So a lot of it is just like, how can we live with it in this phase? How can you be comfortable? How can you adapt to what's happening here? And letting the pain relief that I can often provide in that session be valuable in and of itself. Again, that's more of that reframing away from let's fix it so it doesn't hurt anymore, to saying, okay, let's find out about it. Let's find ways to care for it, find out what you can do and I can do to help you be with this issue.
Yeah. I want to also draw attention for just a moment back to something that you were saying at the outset here of our treatment discussion, of when you were thinking that you were making all of these frozen shoulder complaints resolve early on in your treatment process. There's also the tendency for us to sort of, I don't know, cross over our understanding of what's happening in some of these instances and maybe develop some overly optimistic ideas about our therapeutic effectiveness because, for example, we might have had people with diagnosis of frozen shoulder who got better really quickly. And I've seen this a lot in, demonstrations by practitioners who are advocating a particular treatment strategy, and then, bring somebody up to the front of the room who supposedly has frozen shoulder, do some things with them, and all of a sudden, they've got this miraculous great range of motion. And we've, broken their adhesive capsulitis free. So I think there's an important distinction to recognize. That's
in
one
quotes. You
really
put that in
good
quotes,
illustration.
Right?
Yes, in air quotes up there. That's right. Yeah. That's one really good distinction there of like, that's not a capsular adhesion. In that instance, if you get that kind of immediate results with an individual, that's a neurological response that's happening. That one is clearly a functional problem and not a structural capsular adhesion, because there is no mechanism that will miraculously cause capsules to lengthen and loosen from any type of manual therapy approach. So that's another reason why it's helpful if we can make some of those distinctions, so we can know, like, if we got those kind of results, we're probably dealing with the functional neuromuscular one as well.
Yes, and I'm looking for us in myself as the practitioner. I'm suspending judgment. I don't even know yet, and who knows? I am that guy who can take someone up in front of the room and show an amazing improvement in, maybe it is 90+% of shoulders in that session. It's something pretty high. Yeah. Enough to support my cockiness around that. But the question, the question there is, does it persist? Not can I get the results right there, because often I can, but how long does that persist? And then that's where I start to think about maybe other mechanisms, but also like, okay, so this is, never mind the mechanism for a second, this is an ongoing project more than a one-time fix. That's the big shift in my thinking, and the one that I want to invite the client around. Yeah. Okay, so that third phase, my treatment thoughts in that third phase, if someone's had the inflammatory phase, they've had the stiffening phase, and then it's starting to improve into the thawing phase, I want to support that with more mobility. Maybe I'm starting to renew the experiments around challenging it a little bit. Maybe I can go back and check and see, what if we do challenge it a little bit more in terms of its range of motion? What if I think about mobility more than desensitizing, and seeing how people respond? So it's time to recalibrate my approach, but then it's also helping the brain essentially recalibrate to the movement that's becoming possible. Because a lot of times people will have forgotten they can move comfortably, and they're still acting as if they can't. The brain is still acting as if it hurts when their body suddenly realizes, actually, I got more range there than I thought I did. And so it's encouraging people to be a little more novelty seeking, to take maybe gentle risks, and then especially to learn how to back off from that when inevitably someone goes too far with that process and gets too excited. Yeah. And then throughout that process, I'm thinking about my CALMS acronym, the inflammatory acronym that we use in our inflammation training. We're the sea of calms is really the context we're working in, because there's so much about our conversation and our relationship and the fact that this person is coming to me, et cetera, that is part of the results we're going to get with an inflammatory situation. The A being the autonomic responses. I'm helping them calm down their reactivity, their autonomic fight or flight reactivity around the pain and problems they're having. The liquids, the L in the calms is the liquids. I'm helping perfusion and circulation. No matter what phase it's in, that's going to be helpful. I'm not, pumping them around, but I'm thinking in my mind, okay, so how could the perfusion of their interstitial fluids, their lymphatic system, their blood, etc., be part of what I'm providing or fostering or encouraging? And then the M being the movement safety. How can I help someone find movements that are more safe, even if they're micro movements in some phases? I should say, though, it calms with an S on the end. I'm not typically doing the S for, if I really suspect an adhesive capsulitis or frozen shoulder. The S is the stimulate inflammation. That's where we'll really challenge it sometimes in certain cases with certain clients, certain conditions. Frozen shoulder is probably not one of those, where I won't necessarily try to stimulate an inflammatory response through really pushing it to see if that will resolve the inflammation. That'll tend to flare things out pretty predictably.
And I think that's also reflected a lot in the traditional physical therapy approaches for dealing with this, that when individuals try more aggressive exercise routines, it often flares the problem up more significantly than helping it. So that would tend to support that idea as well.
And so much of what I'm helping people with is the pacing, helping to learn how to pace what they do.
Yeah.
Okay. So, any key points we should repeat here and wrap up? What do you think?
Yeah. So, there's a couple of things that I think that we sort of highlighted as key points here that we would want to look at. So you had mentioned that just because some shoulders have a limited range of motion or stiff in certain planes doesn't necessarily mean the individual has frozen shoulder. And that's certainly, I would emphasize again, the crucial importance for trying to go through a comprehensive evaluation process and have a good idea what's going on there. So that doesn't necessarily mean that is a frozen shoulder, especially if it's not following a characteristic pattern that we would likely see with that. So,
nice.
What else you got? Yeah. So,
well, it's that last point I made. I'll just repeat it. Be aware of the potential for flaring it up or backlash if you get too ambitious or aggressive, even if it seems to be okay in the moment. You got to learn how your clients are responding and keep that in mind as you're working as well.
Yeah. And you had mentioned too, just trying some things out and seeing what happens, both in terms of range of motion capabilities, both in the assessment and evaluation process and also in the treatment process, kind of just seeing where we can try to restore some functional movement in even very, very small little increments as much as possible. And, often encourage people to do this in ways that don't load those tissues too at home, because this is a real important part of this, is trying to reinforce ideas in home. And there's things like the doorway stretch, where you place your elbow in 90 degrees of flexion and put your hand straight out in front of you against the edge of a door frame and just try to turn your body a little bit. So you're not thinking about turning your shoulder, just turning your body, and that moves your shoulder a little bit, and just doing those kinds of things repeatedly, just a little bit at a time each day is really helpful for especially those neurological problems where you're sort of teasing the idea of moving farther into that barrier and telling your body it's safe to move.
Yeah, and a nice variation on that to grade that back is the corner stretch. Instead of a doorway, just go into the corner, face into the corner, and put your hands on the opposing walls and lean into that. That can be a little less intense than the doorway stretch. But the key there, like you said, Whitney, is to really the grading, the ability to pace what you're doing and learn from how aggressive you're being with yourself and back it off if you need to.
Yeah,
so that's
absolutely.
That's the patience, the experimental approach, the patience of caring for it rather than fixing it. And then I got one more. Should I share mine?
Yeah, definitely, Ben.
And that's the pain relief, even if it's temporary, is really often possible, and it's really valid as a benefit, even if it's temporary, even if it doesn't last, because again, that can shift someone's thinking about what's going on, and any relief from an ongoing situation is a godsend. and it helps people reevaluate their expectations and what they're demanding of themselves, just to give them an experience of some relief and pain, and that being itself being part of the care that we can give something like a frozen shoulder.
And I think this taps into what we were saying earlier too about just small wins. You know, what you're talking about there is like finding ways to give people small sensations of progress and making some headway. Those are always particularly valuable in this condition because it can seem so long and so debilitating. You know, we're talking about a condition that frequently goes on for 18 months or 2 years in many cases. So those little bits of improvement give the person encouragement to keep working and keep trying things. That's so important.
That's great. Yeah. Well, we probably ready for our closing sponsor?
I think so. I think we kind of wrapped that up pretty thoroughly there. So what do we got here closing us out today?
Books of Discovery is our closing sponsor. They've been a part of massage therapy education for over 20 years. Thousands of schools around the world teach with their textbooks, e-textbooks, and digital resources. In these trying times, this beloved publisher is dedicated to helping educators with online-friendly digital resources that make instruction easier and more effective in the classroom or virtually.
And Books of Discovery likes to say learning adventures start here, and they see that same spirit here on the Thinking Practitioner Podcast and are proud to support our work knowing that we share the mission to bring massage and bodywork community enlivening content that advances our profession. So check out the collection of e-textbooks and digital learning resources they have for pathology, kinesiology, anatomy, and physiology at booksofdiscovery.com, where Thinking Practitioner listeners can save 15% by entering Thinking at checkout. So thanks again to all our sponsors. If you will, stop by our sites for the handout that Till mentioned earlier, show notes, transcripts, and any extras. You can find that over on our sites. For me, that's over at academyofclinicalmassage.com. And Till, where can people find that from your site?
I'm at advancedtrainings.com, and we'll be sure to put the link to the shoulder jam there as well. We highly recommend you come check that out with Whitney, me, and a bunch of other teachers. If there's any questions or things you want to hear us talk about in our podcast, email us at info@thethinkingpractitioner.com or look for us on social media. I'm at my name, Till Luca. Whitney, where do people find you on social media?
They can also find me on social under my name, Whitney Lowe, and we would also encourage you follow along with us on Spotify, rate us on Apple Podcasts, wherever you happen to be listening, Stitcher, whatever is your podcast app of choice. And as of course usual, if you are unable to find us in any of those locations, you can always find a railroad track that runs from north to south across Saskatchewan and put your ear to the track and listen to us there. So thanks again for another interesting episode. Till, great to talk with you about this, and we will see you again in 2 weeks.
Likewise, I enjoyed it, learned a lot, and always a pleasure. See you again in 2 weeks, Whitney.
Okie doke.